Hello everyone, I am Dr. Aravind Kudva, Additional Professor, Department of Conservative Dentistry Endodontics, Yenepoya Dental College. Today I am going to present a topic which is most commonly topic which we encounter in our routine dental practice. That is deep caries lesion, and how do we exactly manage those deep caries lesion. Coming to the specific learning objective, to define deep caries lesion, their etiology, progression and clinical as well as radiographic features. To describe the ideal pulp capping agents, their clinical applications, to list biomaterials, their composition, properties, advantages, disadvantages and success rates. To explain the treatment approaches including indirect as well as direct pulp capping and pulpotomy. Coming to the introduction, what do you exactly mean deep caries lesion? Those are those lesions in which caries penetration is easily observed in the dentine and may involve more than 1/2 of the dentine thickness between the dentino-enamel junction and the pulp. Before going deep into the topic, we have to understand what is infected dentine and what is affected dentine, and what is the exact difference between the infected dentine as well as the affected dentine. Now coming to the infected dentine, it is basically characterized by irreversibly denatured collagen which is infiltrated with bacteria. It is generally not remineralizable, unlike the affected dentine which is remineralizable, and it is to look it will appear more darker in color and consistency will be more softer than compared to the affected dentine. Now what exactly you mean by affected dentine? Affected dentine is characterized by reversibly denatured collagen which is not infiltrated with bacteria, it is bacteria free. It is remineralizable. It either remineralizes or becomes sterile upon once the cavity is thoroughly restored. That is why we have to understand one point here. Infected dentine has to be removed for success of your pulp capping, whereas affected dentine can be left behind. Now what are the various dyes to differentiate this infected as well as affected dentine? The most commonly used dye is basic fusin dye. 0.5% basic fusin in propylene glycol is used. This fusin is applied to the dentine for about 10 seconds. Irreparable area of dentine will distinctly stain red in color. The nature of the collagen fibers constitutes the difference in stainability of the two layers of the dentine. This is how it will appear once the dye is there. So we can now easily differentiate the dentine, infected dentine, which can be scooped out with the help of a sharp spoon excavator. Now coming to the next dye, acid red dye is also used. 1% acid red solution in propylene glycol is capable of differentiating these two layers of the caries dentine. Now how do you manage this acute and chronic decay? The first most common procedure is indirect pulp capping. What by definition indirect pulp capping means it is a procedure wherein small amount of caries dentine is left in the deeper area of the cavity preparation to avoid exposure of the pulp, followed by placement of a medicament to seal the dentine and encourage pulp recovery. The medicament used most commonly is calcium hydroxide. Now let us go into the objective of indirect pulp capping. It is basically done, first thing is to avoid pulp exposure, second to stimulate the pulp to generate reparative dentine beneath the caries lesion. Now what are the material used in indirect pulp capping? The first most commonly used material is calcium hydroxide, second is zinc oxide eugenol. Acid etched and bonded composite also has been used. Dentine bonding agents also are used, and in glass ionomer cement, resin modified glass ionomer is most commonly used. Now coming to the indications of indirect pulp capping. On clinical examination, there will be presence of a large caries lesion. There will be an absence of lymphadenopathy. The adjacent gingiva will appear normal. The tooth will have a normal color. Abnormal color of the tooth means a non-vital teeth, whereas in cases which we select for a indirect pulp capping will be a vital tooth. So the color of the tooth will be normal because the tooth will be vital. Now coming to the radiographic examination, there will be presence of a large caries lesion in close proximity to the pulp. the lamina dura will be normal and intact. Periodontal ligament space will be normal. There will be no signs of any, or radiograph will not show any periapical radiolucency. Now, what are the contraindications for indirect pulp capping? History, there will be a sharp penetrating pain that persists after withdrawing stimulus. Prolonged spontaneous pain, particularly during the night. Clinical examination, there will be excessive tooth mobility, tooth discoloration, and non-responsiveness to the pulp testing technique. On radiographic examination, there will be large caries lesion with apparent pulp exposure, interrupted or broken lamina dura, widened periodontal ligament space, radiolucency at the root apices or furcation area. Now, there are two methods of indirect pulp capping, like two procedures. One is one-step procedure, another is two-step procedure. Each of the procedure has different advantages as well as disadvantages, which we will now know. Now, coming to the one appointment technique or one step procedure, this was actually put forward by a person called as Pitford. The complete demineralized and discolored dentine is removed, leaving a thin layer of residual caries, and re-entry is generally not undertaken. Because according to the Pitford, he suggested that re-entry to remove the residual minimal caries dentine after capping with calcium hydroxide may not be necessary, because while doing that there is a chance of pulp exposure, and it might later cause problem to the tooth going for root canal. So, once the tooth is completely sealed with a good restoration and the tooth is asymptomatic, there is no need for a re-entry. In two appointment technique, the first step is focused basically on excavation close to the residual level of caries, leaving the dentine behind to facilitate a biological response from the vital pulp, whereby tertiary dentine can be produced. At the re-entry, the retained caries tissue has to be removed. Now, coming to the technique, in the first sitting, we have to establish a proper cavity outline with a high speed handpiece. Remove all the peripheral caries dentine with a large round burr in a slow speed handpiece and a sharp spoon excavator. Now, remove the majority of the soft and necrotic infected dentine. Now, fluoride application is very useful here, because it will help in remineralizing the affected dentine which we are leaving behind. Now, cover the remaining affected dentine with a suitable therapeutic restorative material. Most commonly used material, as I said, was calcium hydroxide. Now, fill the remaining of the cavity with a reinforced zinc oxide eugenol cement. Why? Because we have to wait for 6 to 8 weeks here. So, your conventional zinc oxide eugenol is not able to stay so long. So, we have to use a reinforced zinc oxide eugenol cement. Now, in the second sitting, which I said, which is 6 to 8 weeks later, a radiograph has to be taken to check for whether there is a reparodentine that is formed. Once you are sure reparodentine is formed, start your second sitting, that is the remaining affected caries dentine will now appear dehydrated, dry and flaky, and now it can be easily removed. The area around the potential exposure should appear whitish and may be soft in consistency. This is nothing but the pre-dentine that is formed. Now, cover the entire floor with the calcium hydroxide material. Now, the base should be placed with zinc oxide eugenol cement, or a glass enomer cement also is ideal, and then the tooth should receive a final restoration. This is how the first sitting looks. It is close to the pulp, but then there is placement of a calcium hydroxide as a sub base, followed by a reinforced zinc oxide eugenol cement as a temporary restoration or intermediate restoration. Then 6 to 8 weeks later, you can clearly see a pre-dentine that is formed there with a good permanent restoration. Now, coming to the next procedure, that is direct pulp capping. Now, what will happen? A question arises, what if pulp gets exposed while we are removing the caries? What is the next treatment for such kind of cases? Such kind of cases, when the exposure is a pinpoint exposure, direct pulp capping is the procedure that is of choice. Now coming to the definition, what is direct pulp capping? It is a procedure wherein dressing is placed directly on the pulp exposure, but we should remember here one point, the exposure should be only pinpoint. What is the objectives? To seal the pulp against the bacterial leakage, to encourage the pulp to wall off the exposure site by formation of a tertiary dentine, to maintain the vitality of the tooth. Now pulp capping for young permanent tooth, indications. We have to know what are the indications for direct pulp capping. Either accidental pulp exposure, which might have been caused during the cavity preparation, or while placing a pin, or a traumatic injury also resulting in pulp exposure. Second indication for direct pulp capping is exposure caused by removal of caries dentine. In both of the indications, the prognosis is better for the first indication, that is accidental pulp exposure, because in this case the pulp will be more healthier compared to the second case, where the pulp can be partially necrotic also. Now coming to the contraindications of direct pulp capping, a wide pulp exposure, radiographic evidence of pulp pathology, history of spontaneous pain, presence of excessive bleeding which cannot be controlled at the exposure site, excessive tooth mobility, purulent or serous pus discharge from the exposure. These are all the contraindications of direct pulp capping. Now coming to the medications and material used, antibiotic, corticosteroids are commonly used, calcium hydroxide is used, zinc oxide eugenol, dentin chips, collagen, polycarboxylate cement, cyanoacrylate, tricalcium phosphate. Now coming to the procedure of direct pulp capping, the most important here you have to understand is isolation, which is both important for direct pulp capping as well as indirect pulp capping. So a proper rubber dam isolation is a must in these both procedures. Now you have to establish the cavity outline. Undesirable or undermined enamel and unsound dentine should be completely removed. The cavity floor and the exposure site should be gently washed and irrigated with the sterile water. A suitable therapeutic pulp capping material is used. Bleeding at the exposure site, now we have to understand it, how to arrest this bleeding. It has to be arrested with the help of a dry calcium hydroxide paste which is placed on the exposure site. If the bleeding is stubborn, and calcium hydroxide powder is preferred, but in just by doing that also, if the bleeding is unstoppable, we have to take a small pellet of cotton which is moistened with the saline, then excess water is removed, dipped in the calcium hydroxide powder to pick up a tuft of calcium hydroxide powder, and this is then later carried to the cavity, placed over the exposed area. The second larger pellet of dry cotton is now pressed over the area to blot the powder dry and to stabilize it over the exposure site. This will completely help in arresting the bleeding. Once the bleeding is arrested, we can end up placing a calcium hydroxide, usual calcium hydroxide paste on the exposure site, then followed by a permanent restoration should then be placed. Pulp capping agent should come in direct contact with the vital pulp tissue without pressure. This is how the picture you can understand here. First the pulp capping agent, then a protective base is done, and then finally the tooth will receive a good final restoration. Formation of dentinal bridge is critical for success of pulp capping. Now after doing direct pulp capping, we have to observe the tooth. If the tooth remains asymptomatic for quite long time, that is say every 3 months recall is a must in direct pulp capping. If the tooth is asymptomatic, then there is no need to do anything, but again if the tooth becomes symptomatic, our treatment plan will change accordingly. Now how do you determine the pulp capping is successful? If the pulp vitality is maintained well, there is any absence of sensitivity or pain, inflammatory responses with the tooth is very minimal, radiographic dystrophic changes are not seen, that is periapical lesion or any kind of changes in the radiographs are not seen, that all suggests that the pulp capping what procedure we had tried is been successful. This is one case of indirect pulp capping where deep caries lesion is there. After the gross excavation of the caries, this is how it looks, and then finally we place a calcium hydroxide there, and then finally sealed with a zinc oxide resinol. And then later recall for second sitting, remove everything, the temporary restoration, and you can see the pre-dentin there, okay, after 6 weeks. Then again you should place calcium hydroxide followed by again base, and then the tooth will receive a silver amalgam, that is the final restoration. These are my references. Sturdivant is one of the main reference, Vimal Sikri. Thank you all.